Great. Well, welcome everyone to tonight's virtual town hall featuring nurses of South Jersey. It's important that this campaign continues to be a resource in these trying times, and I'm grateful for everyone viewing on Facebook and viewing here on Zoom with us. I am so thrilled about this conversation. When I worked in Senator Booker's office as a health staffer, nurses often came in, and I heard about their struggles in their profession and what they needed to do their jobs well. And we know how trying of a time it is for this profession and healthcare workers on the front lines across the spectrum. And so I am thrilled and grateful for essential workers making time in their busy schedules to talk to us tonight. We have Amy, who is a emergency room nurse. We have Janice, who's acute care, ICU patients. We have Rhea. And you guys can put your hand up so people know who Amy.
Hi.
Yeah. Janice, who does acute care. You put your hand up, Janice. We have Rhea, a good friend of mine from high school, actually, from Vineland, who is joining us from, who's an oncology nurse, a cancer nurse in New York City, which we all know is the epicenter of the American crisis at this moment, with New Jersey being a close second. And we have Barbie Harris, who does home infusion therapies as a nurse. And so thrilled to start this conversation. We're going to structure this in a way where we're going to talk about, obviously, the current crisis, but we also wanted to devote a significant amount of attention to the profession as a whole, because the crisis has exposed a lot of needs and gaps in staffing shortages that existed well before the COVID crisis. So much, in fact, that one of our panelists could not make it tonight. Joe and Amy is replacing Joe. We're so grateful for your being here, Amy, because she pulled 2 doubles and has not been allowed to leave that because she's critically needed in her assignment right now. So this is a real struggle. People in real time are dealing with this and putting all they have to fight for their fellow citizens. So we're grateful for Joe despite her not being here. With that, I'm going to turn over to our panelists. I'm going to act very much as the moderator tonight, and I want to start with a few questions. Sort of, I think it's important to know what your jobs look like pre-COVID and what it looks like post, to give our viewers, our participants, a little sort of insight and background about what it looks like to be a nurse right now at this moment. And Rhea, let's start with you. The virus started in New York City. Let's start with you.
Hi, everyone. My name's Rhea. I'm a registered nurse, and I specialize in oncology. I do a lot of education for patients living with cancer. Prior to COVID, my typical daily operations was doing patient education. So when someone comes into the hospital or the center, letting them know what to expect with the treatment process, right? Medications, chemotherapy, patients who go on to have surgery and radiation. A lot of daily operations help with port flushes, medication administration, answering any questions if they need shots or updates or anything like that. Since COVID has started, it's been a lot of on-the-spot training, falling back on basics and knowing that you're a nurse and adapting to new protocols. We do a lot of screening, making sure that everyone who comes into the hospital or into the infusion center is safe, be that temperature checks, asking about exposure to the virus, just symptom checks. And a lot of daily operations nurses are at the forefront, really screening. We might even be testing or swabbing people who are symptomatic and suspicious or who've had exposure. So a lot, in addition to making sure that operations continue, people are getting their treatment, they're getting the care that they need to fight cancer. We're also really screening aggressively for this virus and making sure that people are taken care of.
I mean, and just by the nature of your work, you're dealing with patients who are there because they have the underlying condition.
Correct. I mean, the people coming into a cancer treatment center are people who are immunocompromised, right? They have a pre-existing condition or they have a diagnosis of cancer, in addition to perhaps they had hypertension, diabetes, any other underlying condition. So we are very careful making sure that our patients are safe and protected, because if you have a cancer diagnosis and you're actively on anti-cancer treatments, we are making sure that we don't want to put you at risk for something like COVID or any kind of infectious disease.
Yeah, that's important to highlight. And Janice, I know sort of on that same spectrum, doing acute care, and for our viewers, because I had to learn a lot of these acronyms as well. Acute care, you're dealing with severely impaired patients in ICU, correct?
Will, my primary job is in trauma as a nurse practitioner. I'm an acute care nurse practitioner.
Okay.
And I'm also a manager for about 20 nurse practitioners in our group. So for us, the challenge with COVID, as you said, with nurse staffing, right now there's a shortage of ICU nurses. We as nurse practitioners are responsible for the management of all the patients on the trauma service, from trauma ICU to trauma step down to the ones that are on the floor. However, because all of us have critical care nursing experience, there's a plan in place for all the nurse practitioners within the hospital and even in the outpatient setting to come into the hospital and go back to working as bedside nurses caring for critically ill patients, which most of us have not worked as a bedside nurse in many, many years. Mm-hmm. So it creates a lot of anxiety. And then there's also anxiety related to what's going to happen to the patients that we normally care for on an everyday basis. We don't have attendings that are going to take our spot, and they've already pulled some of our residents to help care for those patients. So how do we then fill that gap to take care of those patients?
Yeah, that's an interesting point. And I know, Amy, are you seeing a lot of this? You're in an emergency room here in South Jersey that you work in?
So the great thing about the emergency room is we really don't know what we're going to see ever. That's one of the reasons why a lot of nurses go into emergency medicine, is that absolutely every night is different than the night before. So right now we're absolutely seeing a lot of patients that are coming in. So we call it kind of like we're either getting a lot of the walking wounded who are coming in with just very, very mild symptoms, and they really don't know where to turn. Like, say, they don't have health insurance. So a lot of the South Jersey centers that we do have require doctor scripts to get testing, even to go to like LabCorp, Quest Diagnostics that are testing, they want you to have a doctor's script. So those patients come in and they want our ER doctors to write them a script to get testing. Unfortunately, the ER is not equipped to do that. You really need a primary care doctor to do that. Or we get a lot of the patients that are coming in that are really the patients that need to be admitted. They need to, obviously, every night we're at least admitting one patient up to the ICU, if not more. And those patients are patients that do need possibly intubation, or they're patients that are looking like they're going to be on their way to intubation. Now, the critical thing with this is that we've learned as time goes on that you don't ever want to put a patient on a BiPAP with this. So if they can't sustain their oxygen on regular oxygen, really the only options that we do have is to intubate a patient, because then we make it more airborne, so you can't put them on a floor with anybody else.
Got it. And I have a follow-up question, but before we move on, I want to let all of our attendees who are watching, please know you can submit questions throughout, and then there will be a 10-minute segment at the very end where we try to address some of your questions. So feel free you can put those in the queue throughout the conversation. But Amy, you said something that caught my attention. I want to dig deeper into before we talk to Barb. So what does it look like when folks don't have a primary care physician at this moment? And so what's happening with that because you're right, a lot of the South Jersey facilities, even to one of my good friends here in Vineland, her husband works at a grocery store, he works at ShopRite, and she tested negative, but she had to go in to get have that initial consultation with a primary care physician to get tested. So what does that look like when you don't have that healthcare, or sort of have that access to that first step?
Now, the nice thing is that most of the hospitals here in South Jersey have set up COVID helplines. So you can call the helpline, and there are some, the urgent carers or maybe like the nurse practitioners that work in some centers that are accepting patients just to come in to get scripts. I don't know how far reaching that is in South Jersey. I haven't really done enough research on that myself, just, working extra shifts at work and, working as often as I do. But as I said, like it's very hard for them to just come into the ER and just state to the ER doctor, I'm having a cough, I'm not really having a fever, but I think I might have been exposed because I work at a grocery store, or I work, doing this, and I don't know who I see, but they just instituted masks here in Jersey for everyone in public. So maybe I might have had an exposure, or, they come in and they're not symptomatic enough for us to keep them, and we're not testing in the ER. So what do we really do from there? Especially if they don't have healthcare, especially if they don't have a primary care provider, where do we really refer those patients besides to the helpline, or besides to the lines that the state has set up?
Got it. And I know none of us are going to be giving sort of medical advice tonight. Or I'm not asking you to, if you would like to. But if for anyone watching right now, and any nurse can answer this, especially Amy, if they should not go to the emergency room first, where should they go?
I would say their best bet is if any of these hospitals do have like the COVID helplines, that would be the best bet. I wouldn't recommend anybody to just come into an ER. We're not really equipped to handle that. If they can call one of these helplines or the state helpline, that's the best bet for them. Maybe they can steer them in the right direction, especially if they don't have the health insurance or they don't have a primary care provider and they're really not symptomatic enough to need emergency intervention. If they just want to get tested, if they're looking for a testing site, if they need to get a script for a testing site, those would be the best bets that I would recommend, that they could possibly find some guidance in that area. Now, I'm not recommending anybody that obviously feels like they need emergency assistance to not come to an ER. Obviously, anybody that's short of breath, that's having difficulty breathing, those are reasons you would want to come into an emergency room.
Yeah, thank you for that. It is kind of scary because some symptoms are much more drastic than others, right? Like the shortness of breath, and respiratory issues have been sort of the what we've been told are the top line symptoms. But if I've heard fatigue and things of that nature. It's kind of hard. But if you definitely are having trouble breathing, that would make the most sense. Barb, I want to transition to you. Oh, Bria, did you have a point? Sorry.
Yeah, I just wanted to follow up with Amy. She makes a really good point of coronavirus has highlighted the need for primary care providers, the need for primary care doctors. Right now, we're in the middle of this crisis and we're working really hard to get people through it. But it is a novel virus, meaning we don't know what it's going to look like 5, 10, 20 years from now. People are going to need follow-up even after they've survived coronavirus. They're going to need follow-up with a good primary care doctor, possibly an infectious disease specialist. So I think this really brings to light the need for more providers and just the demands of the community and people having access to good quality care, because we can talk about the 14-day quarantine, but moving forward, anyone who's been exposed and surviving coronavirus, they're going to need follow-up care. So we really need to be thinking about like what does this look like long term, because we don't know. We just don't know how things will play out.
Yeah, especially given the fact that it looks like there's a national dialogue happening amongst our elected officials about when to quote unquote reopen the government and reopen the country. And so, that assumption of risk we're all going to take, it's as curves flatten, and this is still out there sort of, as our lives begin to change. And, I think I heard Governor Newsom from California say something to the effect of, you may go to a restaurant and your waiter may wear a face mask and you may have a disposable menu, just like really we're all going to be much more aware of these things, but also we have to be aware of the fact that the healthcare needs are going to have to, the healthcare access is going to have to evolve with it, because if this is going to be something we're living our lives with, the reality is our healthcare system has to adjust to that too. Well, on that point, I want to talk to Barb, because your practice is a little different from everyone else's in that you are kind of a, Dr. Quinn medicine woman. You're kind of traveling around South Jersey, making sure people have what they need. As a home infusion nurse, I can only imagine how difficult, if you got to, I'm sure you pray that the homes you're going into, people have been practicing social distancing and quarantining. And if they have, then you are entering your home and you are the risk. So what does that look like? And I'm sure that's changed your job in some ways pre-COVID, and just what does that look like now?
Well, the way our practice is, the family is your patient. So if one family member is a danger to you because they're not complying with, the entire family is a danger to you. But pre-COVID, I would have my patient list of visits for the day, and they would know about what time I was coming, and I would just go and knock on their doors. Now I call them the night before and screen them. I check in with them in the morning, make sure they didn't have a fever or any new symptoms. Everybody's been compliant. And then I go into the home, but I go in masked and goggled, because you still don't know there are asymptomatic carriers.
Mm-hmm.
So that's quite a change. 2 phone calls and a whole new outfit to go into everybody's house. And the patients are all very, very different. Some are immune compromised. I've been seeing some recent transplant patients, and I would not want to bring this virus into them. Some other people with chronic immune disorders, and some, children. I don't want to do that,
Yeah.
But you have to screen the whole family. I can't just screen the one person. I have to screen everybody.
And the screening of the family, was that this were you doing that?
I can't just screen the one person. Well, I have to screen my one person, whether they have a fever, but I need to know if anyone in their house is exhibiting symptoms.
Mm-hmm.
You understand?
And that's something that you didn't have to do before the pandemic, obviously.
Goodness, no, we never had to screen for anything.
Oh,
I don't have to screen them, but for safety reasons, I need to screen the whole family, because if one member has a cough and a fever, I kind of need to know that.
Yeah,
So.
And I think that why it was so important to have this discussion, because I do really want to highlight the fact that your difficult jobs have been made a lot harder. Because what it sounds like to me is your workload has quadrupled if you're going to a family household with 4 people in it.
Well, yeah, and not only that, if these people are quarantined, their access to life outside the quarantine is through us, the home visiting nurses. So they're relying on us for their education, their updates, what they really should do. And I know in Cape May County, what we've been telling them is the county has set up through one of the primary cares screening, and you call a number. You can go to the county website and find it. You call a number, they interview you, they screen you, they test you, they arrange for it, the whole thing right from there. And Complete Care is the place that it's happening at. But it all goes through the county, so they can contact the county health department or go on the Cape May County Health Department's website to access that. Yeah.
Janice, I want to pose our next set of questions, starting with you, because what does it look like management-wise, managing other nurses, and sort of what policies have been put in place in the midst of this pandemic that perhaps were needed before and should stay? So what does that look like in terms of all your jobs? Sort of have there been some aspects of this new reality that will continue to improve the profession if we keep them in place?
Sure. I think that one of the things that has been hard for us is not having visitors. We all kind of joke about it at times and say, it's kind of nice to not have visitors, but it makes our job a little harder too. We have to dedicate time every day to call families and make sure they're updated. The only visitors that are allowed right now is if someone is dying, being comfort care, they can have somebody come up. And a woman who's giving birth can have somebody, and obviously a pediatric patient could have a parent, but that's really hard. And it's sometimes hard to, I don't want to say get the group engaged to call families every day, but we have so many other things going on. You now have to take time to dedicate to that. Being a manager, I have multiple phone calls every day because we do all our meetings virtually now, either through WebEx or phone. Every day is a COVID update at 5 p.m. We have other meetings regarding staffing. It's a lot of angst, as I said, with my employees related to, are we getting pulled? Oh, we heard that this group of people is getting pulled. And then there's the whole anxiety about PPE. Fortunately, at our hospital, we've been very lucky to have adequate PPE. There is currently a shortage on gowns, so we're trying to conserve gowns and get people who are ruled out COVID tested quicker to conserve some PPE. But even on our trauma service, we've had people who've come in who, you know, have a fever, a cough, whatever. You don't know if they were in the process of getting worked up, or do they have a hospital-acquired infection, or, you know, did they get COVID somehow? So we've had some of those patients as well. So it's very stressful for the staff, and I feel like a lot of my time every day is spent trying to calm them down, reassure them, let them know everything's going to be okay.
Yeah, it's an interesting point, because I definitely understand the difficulty of not having the ability to talk to people in person anymore.
Yeah.
When you're with the job that you have, your job or the job you're trying to get requires it.
Yeah, it's hard.
Yeah, it is. It is hard to make those kind of adjustments. And so another interesting point you made, because one of my roommates from college actually just gave birth on Sunday. And I was texting with her and her husband this afternoon, and I could not imagine giving birth right now in a hospital. And family couldn't visit. Her husband really couldn't be there until she was released. And so it's just the new reality. And
yeah,
a traumatic. What I believe is that I haven't given birth, will never give birth. I imagine it to be very traumatic. What is already traumatic is becoming more traumatic. Like.
In South Jersey, we're actually seeing patients coming down from New York and North Jersey, because apparently up north, they're not allowed to have any visitors. So they've been coming down to some of the South Jersey hospitals to give birth so that they can have that support person.
Yeah.
Here in New York, you will see every hospital makes their own policies. So at the very beginning, certain hospitals, we don't know what to expect. So you did see hospitals were saying no visitors. As Will mentioned, his friend was unaccompanied. Then you're seeing hospitals that maybe have the resources to screen at the door, which means doing a temperature check and evaluating symptoms and perhaps allowing one birth partner. But this is definitely the managers and administrators here are constantly up to date, reevaluating, checking in regionally. But it's interesting what you're saying, that folks are possibly reassessing where can they get healthcare, and in a situation like a birth, probably just trying to accommodate the birth that they had wanted, which is like definitely a different end of the spectrum for those of us who are working in these other situations like infusion or critical care, end of life care. So definitely folks are trying to get the accommodations where they can, and every hospital has different needs, different resources. So you're really seeing not just stress on us as nurses, but also the stress on the patient, that a lot of the plans that they've made are quickly just changing, and day to day it's changing rapidly.
Yeah. I mean,
also, the ancillary people have been let go, like the volunteer staff. So now the hospital people have to pick up those jobs too.
Mm-hmm.
So we don't have an addition of ancillary people.
And you have people, right now we're not doing any elective surgeries. So you have some people that are required to take paid time off, or who they're trying to find other things to do. People who, obviously now are unemployed, coworkers whose husbands are unemployed, and then you add the virus on top of it, and people really don't want to take it home to their family members. A lot of us have children or parents that live with us. So, it's a scary thing. And then you compound that with the loss of jobs and the monetary problems that go along with it.
Yeah, I think that's a good segue, because what we've seen, Pennsylvania Senator Bob Casey just recently introduced the HEROES Act, and I think it's being described as a sort of a modern day GI Bill for healthcare frontliners like you all, a $25,000 payment for sort of basically putting your lives on the line. A lot of elected officials have called this a war, and if that's the analogy, then you all are definitely on the front line. And I know I speak on behalf of all the attendees and our entire community when I say thank you. But when we talk about, because what we're seeing on display is sort of a profession that is being stretched thin, and that's putting it nicely. There were staffing shortages. We know this before COVID came into our country and tested our healthcare systems, the capacities of it. And so what does that look like about, we need to address those shortages. And I do believe the way we treat the profession and frontline workers and nurses in particular at this moment is going to either accelerate closing that shortage, or it's going to exacerbate it. So I want to just hear your thoughts on that.
I think it's different for every institution. I think where Rhea's at up in New York City, those staffing shortages have really been exacerbated and highlighted, and the lack of PPE and how some institutions have treated their employees definitely didn't help the situation in places where nurses already didn't feel valued, and there's been issues over the years with how nurses feel about the profession because of how different hospitals have treated employees. And then you have the whole issue of patients and violence in the ER that Amy can probably speak a little more to. But, nurses and other healthcare providers recently have experienced great burnout. And I don't think that this is going to help it very much. I think that hopefully the public will have a better feeling and appreciation for healthcare staff, but we'll have to see.
Anyone else want to address that question?
For me, that you mentioned violence in the ER. Before all this even started, we actually had instituted a policy that we became a no tolerance facility. So there was no tolerance for physical violence, shouting, anything. But yeah, burnout in the ER is a huge thing. So before I became an ER nurse, I was actually a brain injury recovery nurse at a rehab center. And I saw less physical, emotional, you name it, than I there with patients that really didn't know any better than I do in the ER. So it is a huge thing, and it hasn't really changed, especially with this whole thing, with limiting patients and limiting, not really patients, but limiting the amount of family members that come into the ER with patients. We're still dealing with it. Our security staff is still on hand at the front desk at all times. I know we're very fortunate where I happen to work that our manager is very 100% behind us, especially with, our PPE, standing behind us, use what you feel like you need to use, because especially in the ER, you don't know who has what coming in anymore. Patients could come in complaining of, my foot hurts, but they could really be a carrier. So she's encouraging us that, if you feel like you need to wear your, you know, your shield, your mask at all times, please do, because you really don't know who's coming in the ER anymore, who has what. So we're very fortunate where we do work, but there's other floors in my same hospital or in other hospitals that I've heard of that their ERs are like that, but their other floors aren't the same. So there's a change, even in the same hospitals where you do work. And I think it's very funny that, you know, some people are like, well, we don't want you walking around like that because we don't want you scaring people, or like, you know, even out in public one day, I was like out of work and I was wearing my scrubs, and I actually was like yelled at in a supermarket. Like, I was going to pick up my mom's medication at, like, you know, the local ShopRite, after I had gotten off of my shift, and a lady was like, how dare you come in here out, you know, out of work. And it's sad because, like, here we are, and yeah, we're on the front lines and we're taking all necessary precautions. I changed out of my personal scrubs into work scrubs at work. So I really wasn't in any scrubs that I had worn on my job. I was in my personal scrubs to wear back home. And, you know, we're still getting verbal abuse when we're not even on the job.
Yeah.
So I think, you know, I was just having this conversation with a coworker the other day that we're getting food brought into work. We're getting coffee dropped off from Wawa. We're getting donuts. We're getting a lot of people calling us heroes, a lot of people giving us praise. But I think when all this is said and done, it's still, you know, we need to have all those people that were doing it now realize that we're still there on a regular basis, and we still do this job every day, and we still face challenges every day, and we're still, even if it's not COVID-19, there's something else that's going to happen again, and it's going to come up again. And Rhea's facing it. She deals with patients that have cancer, and Barb faces it. She goes and she gives home infusions, and Janice faces it. She goes and she deals with her patients. We face it in the ER. We never know what we're going to see. So it doesn't matter what it is that we're facing. We're still there every single day. So it's great to have the acknowledgement right now because we're dealing with something so huge, but there needs to be that acknowledgement all the time. And
even for like those holidays where we know folks are more likely to get in accidents or things of that nature. Yeah, it's the fact that we know when the hospitals are going to be a little busy based upon social drinking.
Right.
You know, that's something that's a reality as well. As you take a sip of water, Janice.
Yeah.
Or a cocktail, no judgment.
I wish.
And this is another reality I want to discuss because, you know, there was the Atlantic, the publication, did an amazing article this week on just how female-driven this profession is. An overwhelming majority of nurses are women. It's a profession that's underpaid, which is emblematic of what we know to be true in this country, that women are not paid for equal pay. And so I want to touch upon that because this is a profession that's now the Frontline Heroes, and it is the majority female. So let's talk about that.
I think I'll speak just a little bit. I think that it is chronically underpaid and under-recognized. And I think we tend to be our worst own enemies in promoting the profession. I think that we need to establish a national nursing union, not just a local union. I think it should be a nationwide union of nurses to protect our benefits, protect our workers' rights, and protect us after we retire. Because many of us will work in the hospital systems or the healthcare systems for 20 or 30 years, retire and lose access to healthcare because there are most institutions do not give you retirement benefits. You'll get a pension, but you won't get any healthcare benefits when you retire. So you better wait till you're old enough to get Medicare, you know, which is, again, another reason to have single payer healthcare.
No. And that was always one of the first things, you know, when I was doing health policy in the Senate and nurses would come and meet with us. And it was always, you know, it was readily apparent there was not a national nursing union. There was definitely one for doctors, physicians, actually all types of physicians. They each have their different associations, whether it was cardiac or, you know, neurology. I mean, they had, you name it, the doctors had their union. So that's a great point, Barb. I'm in agreement with you there. So I guess, as we sort of, we're eventually in about 10 minutes, we're opening up for questions. I just want to remind everyone, please, maybe I'm just not seeing them, but if you have them, please submit them. But I want to talk to you all on a personal level because, I think you all became nurses for, I imagine, to be personal reasons. It's a profession that is deeply taxing and emotionally draining, but also I'd imagine it's fulfilling, and you can do life-changing work on a daily basis. And so, how has, I'm sure, I have no doubt that this pandemic is sort of testing the resolve of, your desire to sort of be that force for goodness in this in your environments, but sort of, it seems more important than ever that folks with great hearts would desire to do good are in these facilities, and sort of want to talk to you about sort of why you became nurses.
I always wanted to be a nurse. I love being a nurse. I'm happy that I became a nurse practitioner. I've pretty much always worked in trauma, love trauma, and it's so rewarding because, like Amy said, every day is different. You may have a patient one day with a bad brain injury, the next day somebody with multiple orthopedic injuries. It's always something different. I loved critical care, and it's very rewarding when you see patients who get better and people who you didn't think were going to make it, and eventually they come back and say, thank you, look how well I'm doing now. And I think each one of us wishes that we could be with Rhea up in New York. We all have that little desire to keep helping people. That's usually why you become a nurse or some kind of healthcare provider. And, we all have to face the reality that we all have jobs. We can't all go to New York and help our colleagues. But, it's the same when 9/11 happened. I'm sure, lots of us wanted to go help them, but unfortunately, there weren't a lot of hospitalized patients, But, it's always, the motivation is doing good, helping people. And I think that's part of why you were saying about nursing is being underpaid and things like that. Most of us don't do it for the money. We do it to help people, and because it was truly our calling.
Great, thank you for that.
I agree with Janice.
Okay. Because we do have sort of, South Jersey is a large region, and I know that the nurses here sort of work in a geographically diverse space. And then obviously there's Rhea who has family here in district and, visits often in New York City. But I want to talk to the three nurses on that are working here in South Jersey. Sort of, are there South Jersey specific needs? What is, whether COVID related or non-COVID, does the job of being a nurse in South Jersey, does it differ because you're in South Jersey in any way?
I believe so. I think that, I primarily work in Cape May County by choice. By choice, I work in Cape May County. And we are geographically limited in facilities. We're geographically limited in where we can pull staff from because we can only go in two directions. And not only that, our population along the whole entire coast, but our population can be so flexible. We can go from 10,000 to 100,000 in overnight. So that has to be taken into consideration. Funding that's based on population size.
I have some technical difficulties. Barbie, still with us?
Not going to accommodate any of our needs during the summer months. So with an elderly population and a declining population. Yeah, I am. Where'd you lose me? Am I here?
Right here, you're good.
Am I here?
Yep.
Okay. I said Cape May County has an elderly population, has a declining population, and things that are funding that's based from the government on our population size will not go very far 9 months of the year. when we have the population flexibilities, as well as the geographic limitations of the area.
And that was one of the points I remember talking to you when it was still sort of uncertain whether or not some of these beach communities were going to be overrun by, folks who were coming from Philadelphia or other places who had second homes. Because my impression is that a lot of the healthcare facilities that are on the coastal communities, they staff according to seasonal population, which is very different on Cape May and Atlantic coastline. Is very different population in summertime than it is winter or right now, the beginning of spring.
And not only our population in the staffing of the hospitals, the availability of consumables. So to have an influx of people from out of town, and I understand they're running for their lives, in their minds, they're running for their lives, but they come down here and our grocery stores were wiped out, and it was amazing. I've never seen anything like it.
Well, Cape May's
empty houses,
and Cape May's first case was not a resident or a native. Right. It was someone who who had a home, who lived in New York City and had a home.
Someone who was put on quarantine. As I understand it, was someone who was supposed to be on quarantine in New York City, but got bored and came down to Ocean City. But that's what I understood. Yeah.
So it is real, and that, for anyone watching in New York or anywhere in New Jersey or actually anywhere in the country, our beaches are closed, so don't go to them. Now, if you didn't know, now you know.
Shelter in.
I think that
stay home. The home where you're.
Yeah.
Yeah. What I'm seeing, being here regionally in New York, folks who have perhaps the means or the resources to leave, so to speak, and really get out of town, have perhaps, if you own a beach home, anywhere. And I think this speaks to public health knowledge and just nursing knowledge and patient education or community education. A lot of people think that nurses, we only work in the hospital, but just helping folks really understand what shelter in place means and staying in place means, not running to Philadelphia or New Jersey, really staying put is when we talk about like flattening the curve. And so much of our job function is not only educating the patients, but also the family members, and really reinforcing like you have to stay put. Shelter in place does not mean go to your beach home. And the strain that we see, it puts on our neighboring areas. I mean, even though I'm physically right now in New York, my parents are in South Jersey, and I call them daily and talk to them daily, and just the daily concerns of our elderly communities, our retired communities, our immunocompromised communities. It's really bringing to light how transient the areas can be, and just one person, in this case, like moving, what a ripple effect it has on the community. So we as nurses are like constantly reinforcing and helping people understand truly what staying put means.
Mm-hmm. Yeah, and I think one of the unfortunate realities, COVID is exposing a lot of inequities in the healthcare system. We're seeing it in metropolitan urban cities across the country. The death rates are staggering, much more deadly for low-income communities of color, and so it's it's vital that that our remedies, our solutions, and our response is we're responding in kind, right? Because what we're seeing certain communities being impacted more, and a blanket approach is not going to fit everyone in all communities, and so that's obviously the job of our elected officials. But I think it was important to note that we have about 10 minutes left. We do have a few questions I'll bring to the panelists, but I do want to talk about I don't want this to all just be doom and gloom. People are recovering, and what does that look like in your workspace, and sort of what is I'm sure it's inspirational to see that, and sort of what does that look like without disclosing personal details, obviously, of any patient.
Rita is absolutely right.
I'll speak real quick. I have a couple patients that I've actually followed from the time that they've gotten into the emergency room We, like I said, we don't test in the emergency room. That's up to our infectious disease doctors. It's up to the admitting doctors. It's up to the hospitalists, whether, patients meet criteria for testing. That's really when they get admitted. But there's patients that, I've kind of followed that have been discharged that have done really well. They've gotten treatment, they've received antibiotics, and within a week's time, they've been able to go home. No intubation, maybe just some oxygen therapy, and they've been able to go home successfully. To my knowledge, those patients haven't come back. So those to me are success stories. There's also patients that we have seen that have come in that have been symptomatic, not symptomatic enough for us to obviously admit, that we do send home on 14-day quarantines, that have not either come back into the hospital to my knowledge. So those to me, I'm also counting as small success stories as well. I think we have to take the good wherever we can find the good, because if we don't see the good in anything, we're just going to focus on the negativity, and then we're just going to lose sight of anything that we're trying to accomplish here. So I think you have to celebrate the small victories, even if it's a small victory of someone that you did send home on a 14-day quarantine that you didn't see come back into your facility.
Mm-hmm. Amy, to that quick point before everyone else speaks, I literally, when I did Teach for America, when I was teaching, the motto was always look for the good, because it was extremely challenging. I think in these professions that are underpaid and are difficult beyond imagination, you just got to look for those silver linings, those really bright spots to keep you going.
Nights in the ER where we are we have bruises that are starting across the bridge of our nose from our N95s, and our feet are so tired that we literally will, wanting to be rubbing each other's feet by the end of the shift. And we're sweaty from our gowns, and, we just want to go home. And I work overnight, so we just want to go home and we just want to pass out. Then there's nights where we don't, knock on wood, see so many patients, and we look around and we said, right now, those are the good nights, because we didn't see so many patients. And we didn't see so many patients, but we know that there's nights that, again, we could be seeing the patients, we could be intubating the patients, we could be sending them up to the ICU, we could be losing the patients. So the nights that we don't see so many patients, we're also taking those as celebrating the good, because that means that nobody was sick enough that they had to come into the emergency room that night.
Yeah.
I think Rhea made a very good point, that in as much as this is a novel virus, we don't know how it's going to behave in the future, that follow-up for these patients is going to be critical. And if we have a population that doesn't have health care and we have no providers for those people, that's going to present a big problem. So I think hooking people into the healthcare system that aren't in it yet is critical. Like I know Cayman County has a homeless population and we have no shelter. So they're kind of lost once they're diagnosed.
Mm-hmm.
I mean, I don't know how you're supposed to shelter in place when you have no home.
Yeah, that is absolutely true. Yeah, there's been, like I said, this is exposed to a lot. There are pockets of homelessness throughout our district. We also know, we've seen the really tragic figures of the skyrocketing of domestic abuse during this time, because home is not always a haven for everyone. Yeah. And so it's a lot of inequities and injustices have come to light that were always there, to be frank. But
in New York City, we're seeing our first waves of people surviving coronavirus. So that's certainly very encouraging, very inspiring. We're looking to science to really guide us on moving forward. What does this look like? And how are we, like we talked about earlier, how are we going to manage these people, these survivors, right, long term? And when we talk about access to care, linking folks into good primary care and even nurses. So, I mean, our patients come in with their physical problems or their medical problems, but we are seeing the whole person. So we talk about a living wage, can people even afford the medications that they might be discharged with? Can they afford to keep themselves healthy with a good nutritional intake, right? So I know when Will was on the Hill, one of the things he really fought was like price gouging with these insurance companies. making sure that people have, people can really afford the medications that their doctors are giving them, whether it be
making sure people can afford hand sanitizer.
Yeah, right. So
running water.
People,
yeah,
get
exactly.
yourself water, get yourself hand sanitizer. And for our people who are on a fixed income, that's certainly a challenge. For people taking any kind of medication, maintenance, or long term, those are other challenges. So like, we can't let like the cost of things dictate care. We really want to make sure that we're equipping people with what they need to stay healthy. And we are, like I said, we're really excited hearing all the, I mean, obviously not to minimize the people who have been lost to COVID-19, certainly, but we are seeing our first waves of survivorship. And that's just really exciting, knowing that we're going to have a place for them and moving forward.
Yeah. So
I wanted to give a shout out. I'm really glad to hear none of you are in a position where you're lacking PPE to a grand extent. And I think that that's pretty amazing since the news, and I wanted to acknowledge all these men and women and companies that are sitting at home sewing masks for people, not just healthcare workers, but people on the streets, and the communities really come together. I know the DAR has done about 98,000 masks to date to donate for civilian use. And there's other groups doing the same, but I think that's pretty amazing. That's the National Daughters of the American Revolution. Yeah.
Got it. So we do have, we have 4 questions. If our panelists are okay staying a little beyond 7 o'clock, I'm happy to, to keep this going. And one of our questions is actually about PPE. So I'll start with that one. How has the profit-driven model of healthcare affected your ability to provide services to patients? How has it affected your access to PPE? Could you imagine Medicare for All solving limited access to patients as well as your personal access to healthcare? Anyone?
Go, Janice.
I don't think that as far as my hospital goes, like I said, we've been great as far as our supply of PPE. We do have a shortage of gowns, which seems to be everywhere, but we've been fine as far as masks, and thank goodness for many of the private sector donors who've donated so much N95s from construction companies, beauty shops. We've gotten private donors who sent us boxes of N95s, and I know Apple today made a donation of masks. So as far as the single payer system, I think Barbie's the one who can answer all that.
I just don't think that it's the job of Apple or the community or Sally's Barber Shop to provide our healthcare equipment. And
no, I agree with that, but obviously we came up very, very short, and I think we need to look at how our supply chain runs in this country. Hopefully bring some manufacturing back to America, but
for sure.
Yeah,
because when we're relying on other countries to get stuff delivered, masks, whatever, it's not as easy as going up the street to wherever they're made and saying, hey, we need another 1 million masks.
Or if they're warehoused somewhere and not distributed effectively.
Right.
Or actually enforcing the Defense Protection Act and having a president that gets America's first, and let's start with America and have them produce these things at the capacity we know our industry can.
Yep.
There you go.
That's probably the most political thing I'll say on that note.
I think unfortunately, as far as like PPE was concerned, I think just every hospital across the country, I just don't think that we were expecting it to be at this capacity. I know my facility, we're in pretty good shape, but we're again doing, everything that we can do to, figure out ways that we can work around things. Is there alternatives to gowns that we can use? Is there, ways that, we can, sanitize N95s, or can't we sanitize N95s? If we can't, we've gotten a lot of public sector donations, as Janice said, Is there a way that we can do something differently? Do we need bonnets or don't we need bonnets? We're looking every day, something changes. So I just don't think that we were totally, and this is across the country, expecting what happened. As far as Medicare for all, I don't know if anybody can see that huge poster in the back, but that's a Bernie.
Hi, Bernie.
So I'm a huge Sanders supporter, still a huge Sanders supporter, so still a huge Medicare for all supporter as a nurse. So as far as Medicare for all, I think this touches on the care for aftercare. I think if everyone was on a Medicare for all system, we wouldn't be worried about these people that don't have insurance today being able to see your provider. I don't think we'd be worried about these people that can't get scripts to be able to be tested, even if they're asymptomatic and we want to know if they're a carrier and they're out there bagging your groceries at ShopRite. I don't think we would be worried about that if we were on a system-wide, nationwide healthcare, whether that be, the ACA with a Medicare for all option, whether that be Medicare for all with an option to keep your own healthcare if you're happy with it, especially if you're a union person and you're happy with your union healthcare. But there has to be something better than what we have now, because what we have now is not working. We have patients that are coming into the emergency room on a regular basis and denying services when they need them to save their lives. This system is not working. So we need to now readdress that. If anything, this whole entire COVID-19 has made a great argument for us to say that our healthcare system is broken and we need something else, and we need to really work on it, and we need to step it up, because healthcare is a human right, and there's no one in this country that should be denied care or aftercare for this virus or anything else. So we really need to step it up and we need to fix it.
Yeah, and in case anyone was wondering, I am in support and publicly out there as being for Medicare for all. So there should be no confusion on that point. To that point, Amy, what I want to say is, I'm sorry, Barb. Go ahead, Barb.
There was a question about if you don't have insurance, and if that's in relation to COVID-19. If you don't have insurance and you're looking for testing, you should call your county health department.
Depending on what county you're in,
Yeah, depending on what county, and call the county health department.
That's a great point. I know in terms of, but we have three
There's
other
also
short
a
questions
state hotline
for,
number.
but I also wanted to point out, we, aside from obviously this is showing us the need for Medicare for all, and I want to sort of put this is slightly unrelated, but also very related, because we know the recession that we're currently in and the depression that we may go into is going to necessitate a policy response that is in equal measure to the severity of the moment. And I've solidly been behind the Green New Deal and green proposals that are job creating, that have prongs of racial equity. And I highly encourage everyone to read a New York Times article that came out today about one of the, little is it known, one of the authors of the Green New Deal is a Black woman, and she did an amazing op-ed today in the New York Times that's the Running for Free, talking about this very moment that we're in, and how the Green New Deal already is a systematic, bold approach to recreating the economy, and we're going to have to do that after this, when we come out on the other side. And so I encourage everyone to read it, especially here in South Jersey. We know our coastlines are severely at risk, rising sea levels. For anyone who's still on Tuesday, we're going to have our next virtual town hall with the author of the book, The Drowning of Money Island. His name is Andrew Lewis, and he's from right here in Cumberland County. And he wrote a book detailing the devastation of South Jersey after Hurricane Sandy. And we're going to be talking about climate change, because just like our government can walk, they should be able to walk and chew gum. We're going to be able to respond in kind to this crisis and be keenly aware that there are crises that existed before this one and that will still be here afterwards. So I with that, I'm good off my soapbox. This is me get off my soapbox. I will, we have just 3 shorter questions before we call it a night. What can we, the average citizen, do to best support nurses and other frontline health workers during this time? Example, potentially putting pressure on local officials or continuing with community mutual aid work. Any responses?
Stay home.
Personal pressure to make.
Yeah.
Stay home. It's the easiest thing that you can do, but it's going to have the most impact. So the governor recently shared, and I'm talking about New York. I'm sorry, Rhea, I don't mean to leave you out, but our governor recently shared the map of New Jersey. South Jersey is still the, so he shared the color map where it shows where we are still looking at the highest levels. South Jersey still has the highest levels, with Cumberland County being the highest.
And the proportion of new cases, right? Like
the proportion of new cases. Now, I was just talking to a friend about this, and it's funny because Cumberland County and Atlantic County are two of the poorest counties in New Jersey. So we don't have, Atlantic County just opened their first testing site, which is by prescription only. Cumberland County, as of right now, does not have one. Again, poorest counties in New Jersey, and again, we're showing the economic differences between North Jersey and South Jersey. So North Jersey was hit harder, obviously, right away because they had the people that are commuting from New York, but they had testing sites right away. They had their PPE deliveries right away. South Jersey, we don't have that. We didn't have that right away. So we're looking at the economic differences between North Jersey and South Jersey. So the easiest thing that especially CD2 can do right now to flatten that curve and make that number lower is stay home. Stay home, limit your exposure, only go out when you need to. It's the easiest thing to do, sometimes the hardest thing to do, especially here in South Jersey, because again, because of the economical and the socio-economical differences, sometimes the people down here in South Jersey have to work 2 to 3 jobs to make ends meet. And those jobs that are,
I agree with her.
You know, those 2 to 3 jobs are minimum wage jobs. You know, I know very well that my favorite cashier at my Dollar General also works at the McDonald's. And I know that her fiance also has 2 to 3 jobs so that they can provide for their 2 to 3 children that they have. So I know that it's easier said than done, but take the necessary precautions when you're out. Wash your hands, use a mask, wear a mask. If you don't have one, there's numerous people out there that are making the homemade masks, or there's numerous tutorials online where you can make one very easily, a no-sew mask with the bandana. It's better than not having one at all. So there's options that you can do, but the easiest thing that you can do is take the precautions, wash your hands, and stay home.
Yeah, and I'm sure no one who's viewing this is this person, but don't think you're the exception. Because my mom is a cashier at a retail store that is deemed essential, and she's told me of people who've gotten attitudes with her because she's asked where their mask is, and she's had to ask them to leave the store. So you know, just do the right thing. If you're watching and don't have a mask, just please get one.
And those people at the retail stores, your mom was absolutely in the right. Enforce it. Make the people leave, because if they're not going to do what we need to do to flatten the curve, then you know they're just as, you know, liable for everything that's going on as the next person. So your mom was absolutely in the right.
Yeah. 2 more questions. What does everyone think about when the New Jersey and the when do you think our states should reopen, or our country, and when do you think that should happen, and what should it look like?
I think the science should guide that. The science should guide that.
Yes.
Great.
Yeah, I agree. Like, we really can't put a date or time. We really have to look to science and look to the numbers, look at new incidences, look at when we talk about new incidences, folks recovering. So we can't put a date or time for sure. I definitely would not put pressure on my elected officials to push reopening if the science doesn't dictate doing so, because we don't want to have another surge. Yeah, we really have to look to the numbers.
I would agree with that. I definitely don't think we should get ahead of ourselves. We're seeing reports about potential a second wave, and that second wave, people are saying if we reopen the right way, it may occur in the fall, but if we reopen too soon, it'll occur very, very soon in the middle of summer, if not sooner, before spring is over. So it does, doing this the right way. We know our government didn't respond initially as quickly as it should, but we need to be responsible about how we move forward on this issue to mitigate the harm that's here. Last question of the evening. I think I know this person. If there were one thing you could ask of our government officials, either local, state, or federal, what would it be? And to this point, this is another, just to add on to that, if there was one policy that you think would make the most difference right now in your profession or in the country, what would it be? In the healthcare context of nursing, not like overall change the world, world peace.
So I'm actually going to start to answer that question. Certainly, again, Ray, I manage oncology patients, people living with cancer, and we talk about getting folks through chemo, but I'm constantly thinking, what does this mean for you 5-10 years from now? We really want you to fight and live a long and healthy life. And when I think about nursing, what does this look like 5 or 10 years from now, or 20 years from now? We don't have enough nurses. We don't have enough nurses. So I'm looking at it in that terms of, I would ask my elected officials to expanding funding for nursing education. Certainly, I think RNs, BSNs, we work in the hospital, but we also need to be mindful that the LPNs, the CNAs, any healthcare worker, folks who want to get on board, we really need to expand the roles. These are people who are extensively trained and they have a lot to offer. So I think certainly we're always hearing, oh, there's a nursing shortage, but certainly I would like to see more funding going into healthcare education and providing a pathway to get more people into our healthcare system who are well and able to do the work and really support us. We didn't have the resources now, and certainly in the midst of this pandemic, it's making us realize that thinking long-term, we need to be thinking about education and funding and really expanding the role of all our healthcare professionals.
I think that one of the things we need to look at is how many nurses graduate and how many nurses 5 years later are still working. I think you'd be astounded at the numbers. And I think there's not really as much as a nursing shortage as a shortage of nurses who will work at this level of care the way we're being treated.
Or a retention issue, yeah.
So I think that getting more help from government, it's a totally different issue, right? Better pay, better conditions, unionized labor, whatever it's going to take. But you asked about policy. I think we need a codified policy on a national level that reestablishes an Office of Pandemic Surveillance, Observation, Protection that can't be altered, just codified, so it can never change. That has no political ties or affiliation, fairly independently run, that will be able to monitor and respond in a timely fashion and do what we need to do to avoid something like this again.
Yeah, and to that point, Barb, we know this isn't, theoretical or hypothetical. We know that in 2018, it was disbanded. It was folded into the pandemic response team that Obama created after the Ebola crisis was folded. We also know that last year, the CDC official whose sole job was to monitor pandemic causing illnesses in China, that job was eliminated. So there are just very simple, very huge red flags with simple fixes that we have to get right. I agree with you completely, Barb. Janice and Amy, do you have any?
So a small policy, I guess it's not small, but a policy that we've actually been working on here in New Jersey and nationwide is safe staffing ratios for nurses. So I think that this is a huge reason why that retention issue that Barb talked about. So nurses graduate, nurses come onto the floor, they pick whatever specialty they want to go into, and 5-6 years down the road, they're burnt out. So they go into different fields. We're not retaining nurses, we're not keeping nurses because we're working ourselves too hard. We need safe staffing ratios across the board, and that means safe staffing ratios for nurses, safe staffing ratios for CNAs, safe staffing ratios across the board. So California is a great model. They have this, it's been in place, it works for them. They retain their nurses, they keep their nurses stay there, they're paid adequately. There's a reason why it works. There's a reason why their nurses stay there, and they like it there, and they love it there.
When I was working, one of my good friends, Nancy, she was a nurse in DC, and she was basically finishing her 2-year requirement that her public service scholarship required if she stayed in DC. She's not from California, but she's moving to California for that simple fact that you just pointed out: better benefits, better pay, better environment.
Yeah.
For the profession. So, I mean, this really can be fixed in New Jersey, and hopefully other states do their part.
It can. And I mean, even if it takes hiring a couple more nurses on the floors, if nurses knew that they were coming into an environment, and say they were coming into an ER or an ICU, but they were only getting 1 to 2 patients, depending on that patient's acuity or depending on what that patient was there for, they're going to be more apt to stay if they know what they're walking into, or they know how many patients they can expect to have. Even in an ER on a night when, you know, you're busy, you might have 5 patients, you might have 4 patients. The acuity on those patients, you don't really know. I mean, I'm very lucky where I work because, you know, they try not to pile that many patients with higher acuities on you. But I have friends that work in other ERs that they're not as lucky. I have friends that work in ICUs where it's not a 1 or a 1 to 2 basis because they're not as lucky, especially small community hospitals. That's why a nationwide safe staffing ratio for nurses it would be so beneficial, because not only for nurses, it's patient care. Patients would get the care that they deserve, especially patients that now are, you know, we're looking at COVID patients. These patients need more care than a lot of other patients that are coming into the hospital, because not only are you fighting now this illness that we don't know that much about, we're learning something new every single day, but you're fighting the patient's comorbidities. You're fighting all these other things that you need to now work as a whole. So it's holistic everything. And, you know, you fight one thing, but then the patient has COPD, the patient has CHF. So now you're fighting a respiratory on top of 2 or 3 other respiratory things. So the reason for all of this, safe staffing nursing ratios and patient ratios just really make sense.
That, and to that point, before you give Janice the last word, you know, I was hearing, you know, the weight requirements and sort of literally like just the ability for nurses to sort of deal with the physicality of the job. It's a physical job at times. And taking that into account when we, you know, build policy that takes your reality into, you know, that's the reality that it's a female driven profession. And you're dealing with people that are much bigger than you physically, whose bodies you're helping carry or turn over to prevent bed sores and things of that nature. So there's a physical part of this job, and that needs to be accounted for in our policy fixes. Janice, the last word is yours.
I would suggest a national nursing license instead of having to have a state license in New Jersey, a state license in Pennsylvania. It's ridiculous. And the other thing would be full practice for advanced practice nurses. Some states don't have prescriptive practices. Some are very restricted. You need a collaborating physician. You know, allowing nurses to practice at the full extent of their license.
Yeah, I mean, and we've seen, and this is sort of emblematic of the crisis, we've seen that suddenly be waived in this great time of need for good reason. Cuomo and Murphy, the governors of New York and New Jersey, letting, you know, nurses come and actually pretty much begging them to come and waiving those licensing requirements, things of that nature. So, you know, I think if it makes sense now, it may make sense in the future. I just want to take this moment. It's been such a great conversation with you all, and I want to reiterate how grateful I am. I understand how busy you are, and you're not working right now, and you should, and you're not sleeping, and you're not resting. You're here talking to me and constituents here in South Jersey, and it means a lot to me. I know it means a lot to them. So thank you, and stay safe out there. You are on the front line, and I don't think it's hyperbole or exaggeration. This is called the Heroes Fund. I'm so very grateful for all the work you do. So thank you so much on behalf of everyone.
Thanks for having us.
Thank you for having us.
Of course.
Thank you so much.
Good night, everyone. Bye, guys. Facebook, stay safe. Take care.
Bye.
Bye.
Thank you.